and aging and sexuality within the context of long-term care. So Maria, I'm going to go ahead and turn it over to you.
Okay, great. Well, first, thank you for inviting me to talk today. I appreciate certainly being able to talk about older adults and particularly within the context of long-term care. So thank you for having me. Okay, sorry. So a couple of things that I wanted to make sure we went over today. The meaning of sexual expression in older adulthood in general, and then also barriers to sexual expression in older adulthood and also within the context of long-term care. Issues of consent in addressing sexuality for long-term care residents with dementia. This is becoming a bigger issue within the context of long-term care. And then also long-term care facility training and some policy interventions related to resident sexuality. So to start with, what is sexual expression in older adulthood? Well, it's difficult to define. There's truly no universally accepted definition, and that's because it means different things to everyone. Some people immediately, when they hear the term sexuality or sexual expression, immediately jump to intercourse, oral sex or masturbation, touch and stimulation, but also signs of companionship, flirting, and romantic affection can be considered types of sexual expression. I know that one woman that I interviewed in a long-term care facility said that she sexually expressed herself by having her hair done every week. It got her some attention from the male residents, and that was one way that she sexually expressed herself. So it's not always that physical form of touch and sexual interaction. And certainly within older adulthood, intimacy is often more valued than sexual activity. As we all know, loneliness is very prevalent within older adulthood and long-term care. So a lot of times it's that intimate, sometimes again companionship, talking, things like that, more so than that physical activity. But we do know that healthy sexual expression provides affection and passion by fulfilling what we consider to be a very natural desire. Sexuality doesn't end as we hit a certain age. We know that it enhances relationships, communication, health status, and mood most of the time. But again, that need for love and affection continues as we grow older. So how do we know all this? A lot of research has been done, particularly within the past 5 to 7 years, I would say, on the older adult population and sexuality. We know 30% of men and 24% of women between 60 and 70 report having sex at least once per week. 26% over 75 report that they're still active. So we do know that it is happening. And then also in sexually active older adults, ages or over 60, 61% said their sex life today is either the same or more physically satisfying than in their 40s. So something to look forward to. What we see is a decline in sexual functioning, but certainly not in desire or interest. Okay, so why is this important to talk about at all? Well, first because there's a significant increase in the number of older adults and an increased life expectancy. So due to improvements in science and medicine, people are living longer. They're also taking better care of themselves, so they know what they need to do to live longer, and they're doing that. More physical activity, and again, those advancements in medicine are helping people have a greater life expectancy. And then the baby boomer population, which statistics kind of vary, but approximately 78 million Americans are baby boomers. So this is a group of people or a cohort that has changed every decade as they've lived it. They lived through the sexual revolution, so it's unlikely that they're going to go into long-term care and say, okay, just tell me what to do. So they're a very, very influential population, and this has major implications as they age and enter the long-term care industry. The increases are 8.8 million people currently in need of long-term care, and then that 85-plus population increased to approximately 5.5 million people in 2010, and it's projected to increase to 6.6 million in 2020. So that's a pretty significant increase for that decade of 19%. I wanted to address sexuality and some of the risks in older adulthood. We have seen an increase in sexually transmitted infections among this population. Viva Viagra, I like to say. Of course, this is something that either helps people to return sexual functioning where there is maybe some sexual dysfunction, and it's very common. It's very out there. So I don't think I can drive on an interstate in any major city and not see a bus or a sign or a billboard with some sort of sexual dysfunction medication being advertised. So we have commercials all over. So people are utilizing these types of medications. Also, there's been a lack of sex education, particularly for that old cohort of older adults. There's been a significant research focus on youth, and this exclusion of the population definitely contributes to the stereotype that older adults are not expected to be sexually active. So that certainly does a disservice to this population. We also see a decline in condom use. People over 50 are 1/6 as likely to use condoms during sex, and 1/5 is likely to have been tested for HIV compared with people in their 20s. You know, a lot of folks that I've visited with just in research over the past couple of years have said that there wasn't really a need to utilize condoms. You know, they were with the same person, you know, for maybe 40+ years, and they either procreated or weren't expecting to have any issues when it comes to STIs and things like that. So there's just generally a lack of education or knowledge in that area. So a couple of additional barriers to sexual expression just in general older adulthood. The media, as I mentioned, sexuality in older adults are really portrayed in a positive light. You rarely see, we do have a couple of celebrities, Betty White is one that isn't afraid to kind of put herself out there and talk about sexuality, but we rarely see it in a positive light. There's a media obsession with those young, energetic, and beautiful people. We see that absolutely everywhere. And there's a term that one researcher uses called bewitchment by expectation, and this is the buy-in sort of to the media's portrayal of sex, that it's only, again, for that young, beautiful population. And older adults sometimes buy into this expectation, and they begin to believe, too, that it's unacceptable for them. Another barrier, excuse me, to sexual expression in older adulthood are cultural attitudes. We all come from different places, backgrounds, upbringings, and we may have fundamental cultural differences across societies with our background as far as religious traditions and our experiences. So again, people bring all kinds of different ideas to the table and may view sexuality in older adulthood as just unacceptable or unnecessary. Excuse me, healthcare providers can certainly contribute to problems surrounding sexuality and aging. They're subject to the same myths and attitudes as the rest of the population. A lot of them have indicated, I know in previous research, discomfort in discussing sexuality with older adults. So even where someone may come in and say that they have sexual dysfunction or that they'd like assistance with a medication such as Viagra, they may avoid the conversation and just write a prescription so that it's easier and they don't have to deal with the conversation. And of course there is a stigma associated with receiving treatment. In one study that, in one manuscript I read, they discussed that a lot of men indicated that they were very uncomfortable going to their physician and then embarrassed to even bring it up. So there is a stigma associated with, as one gentleman said, he felt like he was less manly because he had to ask for treatment. Excuse me. Another barrier, physical changes and then also medical conditions can pose problems for sexual expression. So our bodies change, of course, as we get older. Men seem to struggle with the sexual dysfunction, and women, as the body changes, they experience greater susceptibility to tears and things like that, dryness. So they're more susceptible to some of those infections and things. Conditions that can cause issues, diabetes, cardiac disease, depression, breast cancer, prostate cancer, HIV/AIDS, and then certainly dementia, which we'll cover a little bit more here in the next few slides. So how does this all relate to the transition to long-term care? Well, that transition in and of itself can be difficult. There are a lot of changes going from living autonomously in the privacy of your own home to a more sort of public or shared setting. So, but when it comes to sexuality and long-term care, there's often a lack of opportunity. We know that the widow-to-widower rate is 4 to 1. So there just may not be enough people in your interest pool to select from or of interest who are capable of sexually expressing themselves. So that can certainly be a problem. As you can imagine, a lack of privacy. What used to be personal in the home now may not seem so personal. So, are people, leaving doors open and things like that? Are they just walking into your room? You know, is there even an opportunity to be private with someone if you are sexually interested in them? Family attitudes and involvement. We've all worked with families who know what's best for their loved one, or claim to, and oftentimes, you know, they simply want to be helpful, but again, they can get involved if they're uncomfortable with an intimate or a sexual relationship between their loved one and another resident. They may say, no, you need to prevent that, and threaten to move that resident out of the facility or some other type of involvement. So a lot of times families can impose their own wishes on their loved one or their resident. Fear of staff reaction or ostracism. This is a big one in facilities. Embarrassment to even ask if there is an interest or someone does want privacy with another person or even by themselves. A lot of times this is an embarrassing topic to discuss, and that's why it's often ignored, because it's uncomfortable. And Victorian attitudes towards sexuality. Again, some people, some staff members and things may think that it's unnecessary, or we've heard lots of descriptions as disgusting or yucky, things like that from staff members who have encountered sexual activity among residents. So those kinds of attitudes towards sexuality really turn residents off from even expressing themselves. Gender disparity. I think we've all heard about the dirty old man. That's just kind of a stereotype that men sometimes get if they are sexually expressive or make comments or things like that towards the residents. And then we've also heard the poor sweet little old lady. I've seen a lot of women who are the aggressor in long-term care facilities, but they still have that sort of stereotype as that poor sweet little lady. So kind of that victim idea. And then punitive responses. So are people being punished or moved or separated from other residents because they have sexual interest, and who determines at what level and at what point that's appropriate or inappropriate. So those can all be barriers in long-term care. And as I said, we know that staff have the most direct and most frequent interaction with residents, so they control a lot of the interaction and the daily conversations and things like that among residents. And then they may come in with subjective interpretations of sexual expression. So again, those personal values, beliefs, the upbringing, all of those things come to the facility with the staff member. So it's important that we have conversations and ask them to kind of check those at the door, and we'll get more into that here in a few slides as well. But staff may be uncertain regarding which types of behaviors are considered sexual. So what's appropriate and what's inappropriate. And if they aren't sure, they're certainly not going to know how to address it when it comes up. So what is the staff role in resident sexual expression? We want staff to respect residents' privacy, preserve their dignity, promote autonomy, and then advocate on their behalf if they are comfortable asking a staff member to assist them in being sexually expressive. And we definitely want consistent and quality responses to sexuality among residents. Okay, so how do we get there? How do we train staff on resident sexuality? I think it starts at the very beginning in screening employee candidates for bias, motives, judgments, any preconceived notions. It's so important to ask the right types of questions, to learn whether or not they have a passion for the population in general. I did an interview with someone for a volunteer position recently and asked them what interested them about this population, and they said they had to fulfill community service hours. So that indicated to me that maybe this wasn't the best fit. They were trying to check something off their list, and they really truly didn't have a passion for the population. So it's important to know how to screen and ask the right types of questions to get to that. Do they have a respect for diversity? So all different kinds of people from all walks of life. And do they have the willingness to learn how to do those things, how to respect people who are different, have different medical conditions or different lifestyles. Early employment, facility and staff opinions and expectations, people's comfort levels in addressing resident sexuality have to be clarified. So those conversations have to be had regarding this situation might come up. How do you feel about coming across something like this? If you see two residents interacting in this way, this may be something that you will see. So those conversations have to be had early on. And it's important that the facility communicate, preserving the right to sexual expression, and this normalizes the occurrence so that people aren't as surprised if they do come across it. And kind of in that same vein with diversity, gay, lesbian, transgender, and bisexual elders, this is becoming more and more of a topic. We certainly have a lot of research going on in the research community. This is becoming more and more prevalent. Many LGBT residents have had previous negative experiences in healthcare settings, and this mainly because there's a general lack of information and knowledge to healthcare providers about the risks and needs of the LGBT population. So it's important to convey to staff that all people are equal, of course, and that it's okay to respectfully ask questions and walk through that. What does that look like to ask questions in a respectful manner? And I just like this quote from One Iowa, that our gender identity may or may not match our appearance, our body, and others' perceptions of us. So again, we may perceive something one way, but again, it's important to ask in a respectful manner questions to the residents, so just to prepare staff. Okay, offer staff support in addressing sexual expression. So where the administrators, DONs, people like that, social workers demonstrate comfort, then the staff are more comfortable. Again, we're normalizing the occurrence. So their staff are going to be more likely to ask questions and then execute proper response strategies as well. Empower staff with the authority to make decisions in response to certain needs of residents. So when you empower staff to respond on their own, when you equip them with the skills and the strategies to do so, they're not running to their supervisor or the administrator every time something comes up. So we asked, I worked on some research with Dr. Gail Dole down at Kansas State, and they asked a series of staff, or a group of staff members, what their responses were to sexual expression, and I think it was like 60-some% said that they screamed and ran to their supervisor. So if we can decrease that number at all and equip people with the skills to address it respectfully, as it occurs, then that's what we want to do. Hold regular meetings with staff to discuss the facility policies and expectations. Again, informing people so they know what's going on. They're abreast of all of the things that the facility is doing, the policies. Has anything come up, new policies, has anything changed? And then provide recurrent and frequent training opportunities. So determine what's important and what's relevant. If a new situation has come up, inform the staff and then revisit so that people are reminded of what the policies and expectations are. Create respectful environments, so cultural environments. Again, when we talk about cultural environments, we're talking more about attitudes, how people interact with one another, how the staff and the residents communicate. So demonstrating attitudes of awareness, acceptance, respect of the various conditions and influences that surround residents' sexual needs and desires, and then communicating this to the residents. I always say it's easy to hang a sign, but it's much more difficult to get people to abide by what's on that sign and the meaning of that. So observe privacy measures, knock on doors before entering, honor privacy signs. It drives me crazy. I've seen it happen a lot when I've been in facilities myself. Staff will knock and enter instead of knocking and waiting. May I come in? Again, reminding people that this is their home. They live there. It may be a small room, but it's theirs. So, honor those privacy signs and privacy measures. The physical environment, where space isn't available, residents may benefit from scheduled opportunities for privacy. So where 2 roommates share a room and one resident has a guest coming in, to schedule time for the other roommate to be out of the room during that time period. Or if someone needs alone time, if one resident needs alone time, schedule that opportunity for them to have their own time to themselves. I know one facility out on the West Coast has a kind of like a bed and breakfast type room that they set aside that people can kind of come and go. They sign in their names. They can do so anonymously. One of the names was Superman and Lois Lane. So they sign in anonymously, and they have several hours to themselves where they can have that room and that space dedicated to being alone. So. I know not every facility has the opportunity or the space to do that, but I thought that was a great idea. Initiate conversations across systems. So I think a lot of times the resident is the one that's left out of this. So we have to remember to ask residents their opinions, their needs, and their wants. What do they want? I think frequently we talk around older adults, but many older adults would embrace the opportunity to discuss their sexual needs and health and desires if they could in the right setting. and observe resident and family councils that represent the voices of these parties. Family councils are kind of rare at this stage, but resident councils are in all long-term care facilities. So listen to what they have to say and ask. So it's important, I always push facilities to develop a policy to clarify their views on how resident sexual needs and actions are addressed. And again, this is important because it prepares staff and also residents to understand how willing, to what extent the facility is willing to accommodate resident sexual expression. So some things that I advise facilities to think about are they willing to go so far as to provide condoms, erotic content. This has become a big thing because of technology. A lot of folks have, if not cell phones, they have iPads and things like that. Some of them have laptops and tablets and things, and are they willing to assist them in providing erotic content? Sex education, at what level are they willing to provide sex education to their residents? Excuse me. And again, the technology with videos, computers, and things like that. I know a couple of facilities have a general library, and then they kind of have a library that they keep behind behind the desk, and that's anyone can check videos or erotic content out of there. It's not publicly available in case visitors come in, but a lot of facilities I know are kind of going that route, having some stuff on hand. Define appropriate and inappropriate sexual expression. Again, if staff is unsure of what's appropriate and acceptable and what isn't, they're not going to be sure how to react. So some things to consider: who's participating, what is their cognitive capacity, does one or both residents have some sort of dementia or something like that, memory impairment, is sexual abuse occurring? They have to ask, those kinds of questions. Are both parties willing and able? Does the family or guardian have the right or the need to be informed? This is a tough question when you have, attorney in fact for healthcare. It's the opinion of our office that sexuality is not a healthcare decision to be made by an attorney in fact for healthcare. So these are things that have to be talked about when you're developing a policy. And then location, location, location. I put this on here 3 times because it's really important. Where is it okay to even appropriately sexually express yourself as a resident? This comes up a lot, and it's amazing. I will say one story I have is that residents in one facility that I'm aware of did not have a location to be sexually expressive, so they sort of created their own on what was termed the sex bench, which I can't imagine would be comfortable or private or appropriate. So anyway, so once the facility found out about the sex bench, they were mortified, and of course then they set aside a room and some personal time and space for residents to be sexually expressive. But we don't want things like that happening, so location is important. With regards to inappropriate sexual expression as well, sometimes when it comes to hypersexuality and dementia and various conditions, sometimes inappropriate expression can, be done in the dining hall, so, or other public places. So staff have to be equipped with a strategy for removing that individual and bringing them back to their room, things like that. So location is very important. Document sexual expression in residence care plans. I've spoken with DIA on several occasions about sexuality, and what the main message that I take away from my conversations with them are document. Show that you're aware that it's occurring, that it's safely occurring, and what the facility is doing to protect the resident and also honor their wishes to be sexually expressive. Consider health factors when developing policies. So think about residents' physical and cognitive conditions, varying rates of decline. So somebody, we know that with dementia-related illnesses, the decline is different for everyone, and it affects people in very different ways. So there's no predictable way to determine what's acceptable regarding sexual expression. So every individual or every resident has to be thought of in a different way. And then of course adverse effects on medication on sexual capacity. So it's important to do continual assessments, and health checks. Notify physicians of changes in behavior and well-being. And this is very important. If if a facility notices a significant change in a resident, then that's a red flag and maybe something the physician needs to be notified to do a well check. I know that of one situation where a very faithful religious gal completely changed her demeanor and her behavior. She requested that they had a hair salon in the facility. She wanted her hair cut really short and dyed red. And they asked her, "Are you sure? Are you sure?" And she said, "I'm absolutely sure." And they did, and then she started to request that they order certain types of sexual toys and things, and it was very out of character for her to do these things. So they notified her physician. They did a health check, and she ended up having a urinary tract infection that was impacting her judgment. So things like that, you can see certain changes in people that may indicate there's something physically wrong or medically wrong that needs to be looked into. And of course, when developing policy, it's vital to understand dementia and its impact on sexual expression. Okay, so with that said, there are a couple of different things that we typically see with dementia and cognitive impairment and how it impacts sexuality. There can be, I didn't put this on the screen here, but there can be a complete disinterest in sexuality. It can cease to kind of exist. That's one thing that we commonly see. A second thing is the increased sexual demands. So they could be unreasonable or unrealistic demands or propositions at inappropriate times or locations. I know of one situation where a gentleman kept propositioning his wife at church, and they were in the front row, and she said it made her very uncomfortable. So he didn't have an understanding of that and became very agitated when she rejected him. So that, of course, is a difficult thing to deal with. Loss of inhibition, that's about 15 to 25% of the dementia population. And that's where a lot of staff members have difficulty because there's a lot of grabbing and aggression, maybe some rude comments, groping, obscene language, things like that. So staff have to be aware, and when developing policy, you have to make it a priority to emphasize that this might be happening to staff members when they're working directly with residents who have dementia. Forgetting appropriate public behavior, so undressing, fondling, masturbation. I've been in a facility where they were having an entertainment piano player and musician, things like that, and a gentleman started to take his clothes off and masturbate in the dining hall, and they redirected him to his room so that he could quietly finish. And they did a nice job of handling it, but again, forgetting that appropriate public behavior. Also, it's important to remind staff that sometimes the undressing and things like that, fondling, there may be something else kind of driving that. So if someone is undressing and it appears that it's inappropriate to us, and the woman maybe continues to lift up her skirt, it could be because she has to use the restroom. And as far as the fondling and things like that, or undressing at certain times of the day, maybe they think it's bedtime or they'd like to take a nap. So some things that we may perceive as inappropriate public behavior may be signs of other needs. So staff need to be educated on that. Persistent and uninhibited behaviors that interfere with normal life, those are considered clinically significant, and it's hypersexuality and sexual disinhibition. And at this level, it interferes with the person's normal functioning. So oftentimes when it's hypersexuality, medication is needed, unfortunately, to kind of alleviate these symptoms. Okay, and I wanted to mention, I like to put this at the end because I think it's important, and that people oftentimes interchange competency with capacity. And when it comes to risk versus rights, it's often confusing who gets to decide. Again, as I mentioned, the Office of the State Long-Term Care Ombudsman does not believe that sexual expression or that the decision to be sexual is a healthcare decision. But I wanted to emphasize that competency is a legal finding that allows the court to determine a person's mental capacity. Therefore, incompetency is the lack of ability to discharge or understand health care or financial management decisions. The difference with capacity is that it's the ability to understand the nature and effects of one's acts. So capacity is a fluid concept. A person may have requisite capacity in one moment but lack it in another. So the determination is whether the person has the ability to understand their acts in the specific moment in time. So does the resident understand and appreciate sexual activity? Do they understand a description of the act, the people who are involved, the risks, benefits, alternatives? So just because a person can't make a decision at one moment in time doesn't mean that they can no longer make all decisions for themselves related to sexuality in particular here. So I just wanted to point that out. Okay, so as far as getting some answers, I put a reference in here to Hebrew Home. They have a wonderful policy. They were kind of the groundbreakers with regard to even talking about sexuality among older adults. They have a wonderful website, and they're very willing to share. They have a couple of videos and things like that. So I would strongly recommend any facility or anybody who's interested in this topic visit their website for more information. If you're not sure who to call, I put DIA first. I probably shouldn't have, but when I have questions about sexual expression, oftentimes I'll contact them to see if I can get their input on what they view as acceptable or appropriate and inappropriate. And then, of course, our office, the State Long-Term Care Ombudsman, because we advocate for long-term care residents, and we can help facilitate discussion of any issues in long-term care. And, of course, anyone can call their local or their long-term care ombudsman. Or you can call me. Here's my phone number and email address. So I'm always willing and available to discuss anything related to the topic. So feel free to call me. Oh, there we go. So, and that's all the information I have. Does anybody have any questions, Katie? Okay. Well, thank you very much for being a good audience.
We're good? Yeah. Okay, thank you everybody for coming. That will conclude our webinar this morning, and I believe there is another one in 2 weeks. So thank you very much.